All right, today we're diving into a really smart new way of thinking about cancer care. It's a system designed to make sure that the best medical minds, the real experts, are focused on the toughest, most challenging cases. Let's jump right in. Okay, so for decades, since the 90s really, there's been one gold standard for planning cancer treatment. It's called the Multidisciplinary Team, or MDT for short. This has pretty much been the cornerstone of modern oncology. So, what exactly is an MDT? Well, picture this. You've got a round table with all the heavy hitters the surgeons, the oncologists, the radiologists, all putting their heads together to focus on one single patient's case. It's basically a cancer care think tank, right? And their one job is to come up with the absolute best treatment plan. And you know what? This approach has been incredibly successful. But here's the twist. That very success, it's created a whole new problem. The system is starting to buckle under some serious pressure. You see, as we get better at finding cancer, the number of cases and the complexity of those cases is going way up. These expert teams are now facing what the West Midlands Cancer Alliance calls an ever-increasing burden and workload. To put it simply, the think tank is getting totally overwhelmed. And that brings us to the big question, really the whole point of this explainer. How do we protect this incredible resource? How can we make sure every single patient gets the expert attention they need without completely burning out the experts themselves? So, what's the solution? Well, the answer, laid out in this document, is just a brilliant and honestly really logical next step. They've created something we can think of as a playbook. Now, this playbook officially goes by the name Standards of Care, or SOC. Basically, it's a set of pre-approved game plans for the common, more straightforward cancer cases. The expert consensus is already baked in, so you don't need a massive team meeting for every single patient. So how does this actually work? Well, it's a really simple sorting process, a triage. A new case comes up for review, the lead doctor takes a look and asks, does this fit our standards of care playbook? If the answer is yes, great. They follow that pre-approved protocol. But if it's a no, if the case is complex or unusual or has any kind of red flag, it gets automatically kicked upstairs for a full think tank discussion with the whole team.
Okay, to really see how this works, let's look at two different patients, two different paths.
So let's meet Alex and Ben. First up is Alex. His case is complex. He's what's called a tertiary referral, which just means his local hospital sent him to a more specialized center for a second opinion. His situation is pretty unique. Then you have Ben. His case is much more standard. A low-risk tumor was found, it was removed cleanly, and the lab results that came back are exactly what you'd expect, no surprises. Okay, so for Alex, because his case is a tertiary referral, the path is automatic. The rules are crystal clear. His case must have a full MDT discussion, no question. His complex situation absolutely needs that think tank to give it their full attention. Now, Ben's case is a whole different story. It fits the playbook perfectly. His pathology report shows a low-risk Leibovitz score, which is just a way to measure how aggressive the tumor is, and the surgeons got clean margins. So, the playbook says his next step is simple surveillance. It's a super safe, really efficient way to manage his care without taking up an hour of the entire team's time. And the level of detail in these guidelines is just, wow, it's incredible. For example, there's this really specific measurement on a CT scan. If a small kidney mass shows more than 15 Hounsfield units of contrast enhancement, boom, that's enough to trigger a full MDT discussion. It's that kind of precision that makes the whole system so safe. Okay, so right about now, you're probably thinking, wait a minute, is streamlining care like this actually safe? And that is a totally fair question. The good news is the system was designed with that exact concern in mind, and it has multiple safeguards built right in. And here's the most important one. The playbook is a guide. It's not a set of handcuffs. The lead clinician, the doctor who is actually in charge of the patient's care, always has the final say. If they have even the slightest concern, for any reason at all, they can just say, nope, we're discussing this one, and send it to the full team. That human oversight is absolutely crucial. The system also has these built-in red flags. These are the non-negotiables, the things that always trigger a full team discussion. We're talking about things like all tertiary referrals, complex kidney cysts, any cancer that comes back, or even if a patient might be eligible for a clinical trial. If any of those pop up, the case goes straight to the think tank. End of story. On top of that, before any decision gets made, whether it's following the playbook or gearing up for a big discussion, there is a checklist of information that has to be there. The guidelines call it a minimum clinical data set, which basically means you can't make a call without having all the key facts, like the patient's age, other health issues, and the exact cancer type, right there in front of you.
So when you put all of these pieces together, what you end up with is a system that isn't just faster, it's fundamentally smarter.
And I want to be super clear about something here. This is not about reducing care or cutting corners. Not at all. It's about reallocating the single most precious resource in the entire system, the expert's time. It's about taking that brain power and focusing it like a laser beam right where it's going to have the biggest impact.
This really brings it home. By using the playbook for, say, the 70% of cases that are more straightforward, the team can now pour all of its energy into the other 30%, the complex ones, the tricky ones, the cases that truly need that full think tank deep dive.
You know, the source document itself says it best. The whole goal is to maximize MDT management discussion for patients with complex disease while protocolizing the management of patients with less complex disease. It's all about finding that perfect balance and focus.
So, what's the big takeaway from all this? It's simple, really. By creating this smart, safe playbook, cancer care becomes more sustainable for the doctors, it's way more efficient for the health system, and most importantly, it's more effective for every single patient.
This really is a powerful model, and it makes you wonder. It kind of leaves us with a big question, right? Where else in healthcare could we use this idea of balancing expert-driven rules with truly personalized care? It's definitely something to think about. Thanks so much for watching.